questions now for Dr. Iyengar. Um, One of them is asking about the role of surgery for local therapy for patients that have oligoprogression on TKI. And then the second is regarding the use of radiofrequency ablation specifically for adrenal nodules and if that is an effective local therapy. So if you could comment on both of those.
Sure. I think surgery is a very reasonable approach in treating oligoprogressive lesions that are amenable to surgery. Most places, we really should take a multidisciplinary approach to talk about what is the right modalities. We shouldn't jump straight into radiation. We shouldn't jump straight into surgery. We should not even consider local therapy unless it's a multidisciplinary decision. I think that's really the best approach. But surgery is definitely on the table. A number of these studies incorporated surgery. It just happens to be that it was used about 20-25% of the time in some of the studies, and radiation about 70 to 80% of the time. But it's a very reasonable approach. Isolated lesion in the lungs. You can have a segmentectomy, or you don't need a necessarily lobectomy. I think it could be very good. Now, with respect to radiofrequency ablation, I saw the question, and part of the rationale for the question was that the patient wanted to stay on his or her TKI and was worried and was thinking that ablation would allow them to do so with less toxicity. As Dr. Higgins pointed out, we can get patients in for radiation in and out extremely quickly these days. We can even do one fraction SBRT regimens that would provide some durable outcome in the adrenals. We could do three fraction regimens. We could do things very quickly. And so for those institutions that choose to put the patients off the TKI for a few days, this really ends up being a few days. And like Dr. Royce mentioned, um, there's really limited data to suggest that the disease is going to become resistant within that short time frame that they're off the TKI. And then the final thing I'm going to say is that there's just not a lot of randomized data, even early, small randomized phase 2 type of data of any kind, let alone very rigorous prospective collected data that suggests that ablation is a durable treatment for metastatic disease. When do I use ablation? I use ablation if I've treated a patient with SBRT. There happens to be an infield failure, unfortunately, which is rare, and then I can't radiate again. Then I refer the patients for ablation.
That's exactly how I use radiofrequency ablation as well. So we tend to go the SBRT route and then use it for salvage if we need to.